Good afternoon, everybody. So in the last class, as a basic electrolytes, dysosmolality, and the water disturbances class, we discussed hyponatremia. So today we will be dealing with the opposite of this hyponatremia, that is hypernatremia. So this hypernatremia is one particular topic where even after centuries have gone, the things have remained changed. That means there has been a lot of difficulties in understanding the concepts, and there is a lack of, I think, there is a big knowledge gap while managing the hypernatremia, even during the diagnosis. Many of the people usually fear when they see hypernatremia, but it is not the case. It is indeed much easier than hypernatremia, both to diagnose and to manage. Even the centuries go over by, the guidelines are not going to change. The things are going to remain the change. It's unlike the diseases in the other categories where the new drugs keep on coming as the year progresses. But it is hypernatremia is one such disease where the treatment will going to be remain same for the management purpose. So everybody of us, while dealing in the emergency or the medicine ward, should know the management of hypernatremia. Even it is very important during the OPD basis also, because many of the chronic conditions, which are pretty common, and some rare conditions tend to manifest with hypernatremia. So this particular electrolyte dysabnormality is indeed a very important thing for pediatricians compared to the physicians, because it is much more difficult for the infants or the neonates to manage with hypernatremia. But in adult, it is very easy. The management is also very easy, where we don't have to fear for the rapid correction, unlike in case of hyponatremia. Only in case of infants and neonates and some pediatric younger children, we need to fear for the rapid correction of hyponatremia. Otherwise, in adults, there is no any danger of hypernatremia overcorrection. Till now, it has been proven in the studies also. So let's start discussing about the hypernatremia here. So hypernatremia is defined as the plasma sodium that is greater than 145 millimoles per liter. So every liter of your extracellular fluid in your body should have the sodium concentration from 135 to 145, the average being the 140, that is the normal sodium. So if the sodium goes above the 145, it is considered as hypernatremia. So hypernatremia is not by itself is not a diagnosis. It is a laboratory finding which can occur in many of the conditions. So when we speak of the plasma sodium concentration, as I told you in the last class also, it is the ratio of sodium that is being dissolved in a single liter of the extracellular fluid, which is majorly water. So anything which decreases the extracellular fluid concentration of water tends to increase the sodium. So this is a basic funda and basic phenomenon here. So any condition which causes a deficit in extracellular water tends to increase the sodium. So if this sodium in the extracellular fluids tend to increase, also increases the osmolality of the plasma of the serum, which tends to attract the water from the intracellular fluid compartment, which ultimately leads to the contraction of ICF volume. So as we discussed in the hyponatremia, the fear was due to the cell swelling. In the hypernatremia, it is the opposite of that, that the fear is here about the cell shrinkage. The size decrease occurs in case of hypernatremia. So we need to understand the link between the sodium and water. As I told you, what is the baseline sodium is the 140 millimoles per liter. So here denominator is the water, that is the extracellular fluid. So every liter contains 140 millimoles per liter. So the 10% means the 14. That is, every 10% decrease in plasma water increases the sodium to 14 by 14, causing 154. And the opposite occurs in case of water gain. Every 10% gain in the plasma water decreases your plasma sodium by 14 to 126. So this is the basic funda. As we told you, any abnormality in the sodium is due to secondary to the primary abnormality in the extracellular fluid, that is water. So the gain in the water is going to cause the hyponatremia, as we discussed in the last class. The loss in the water will cause the hypernatremia, which we are going to discuss in this class. So, in the human body, whenever we face the abnormalities of losing the body fluids, the first and the foremost target is the primary preservation, is the volume preservation. It is not the plasma osmolality. Plasma osmolality is always the second target. The first thing is always to have the preservation of the volume status. So as soon as the plasma osmolality increases, the body tends to release the ADH, where it tries to act on the kidney to reabsorb the water. So the water gain becomes the primary priority. Secondary to that, the change in the plasmolality occurs. So whenever there is a conflict of signals between the osmolality and the volume preservation always takes the priority, and this is the basic physiology in the body. So what happens during hypernatremia? So in the normal conditions, we know the water freely moves across the cell membranes. So the sodium being the major extracellular fluid. So any loss in the extracellular fluid, sodium, moves the water out of the cell, which will cause the cell shrinkage. This is the fear thing about the hypernatremia. So why this hypernatremia, or how this hypernatremia occurs? This can occur by directly the gaining of the sodium, that is the positive sodium balance, or most commonly it is due to negative water balance, that is the loss of the water from the extracellular fluid, which is going to cause the hypernatremia, which is very, very important. So in 90 to 99% of the cases of hypernatremia, it is usually due to loss of water. Only rarely it is due to primary gain of sodium, which is very rare. We'll discuss that later. But whenever you see a patient of hypernatremia, first thing to know is the deficit of the water patient is going to have. So, how this primary water deficit can occur in this patient? It can occur through two mechanisms basically. Either the patient is not taking this water sufficiently, or the patient is losing this water from the variable sources. So, if the person is having a lack or the inavailability of the water, like the person has gone to trekking, he has not drink enough of water, person is in the desert, he has not got the enough amount of water, so he is supposed to develop the primary water deficit. Or the patient has the inability to gain access to or to drinking water. This can occur in the elderly people who are chronically bedridden, or the patient who is unconscious, or the very young child, like the infants, neonates. If they are thirsty, they cannot tell that they want the water. So these can cause the primary water deficit. And the primary defect in the thirst mechanism itself is abnormal. Like patient is not feeling the thirst at all. For example, if the patient has an altered mental status or the psychological disorder, like schizophrenic patients might have the hypodipsia, or the diseases involving the osmoreceptors. There are some diseases which can directly involve the osmoreceptors, and diseases involving the thirst center directly. Any abnormality in thirst center, patient may not feel any thirst. Whenever we do some exercise, whenever we go in a very sunny day, summer days, due to excessive sweating, we usually develop an immediate thirst, which tends to make us to drink water. If thirst is not there, if patient is not developing thirst only, patient is not going to drink enough water. So this primary water deficit is going to cause the hypernatremia in the due course. Although this is very rare, but this has been very common in case of a chronically bedridden elderly patient. For example, if the patient is having some fracture of the leg, who has been chronically bedridden, along with many comorbidities, the patient is not drinking enough water. So this is the usual case when we sit in an emergency, an elderly patient coming with a severe dehydration, which is secondary to reduced intake of the water. Or if the patient is unknown, who is been lying in the roadside for many days, suddenly the police people brings you to the hospital, you see his sodium may be picked up to 160, 170. This has been the very common in case of medicine emergencies in the medical colleges. So the next cause among the primary water deficit is increased water loss. The person is losing this hypotonic water in excess of the sodium from many sources. Like if the patient can lose this water from the renal loss, as we know that the antidiuretic hormone is essential for the water reabsorption from the collecting ducts. If this antidiuretic hormone is not secreting properly, or if it is not acting properly, the kidneys collecting ducts cannot reabsorb this water from the collecting ducts. So this excessive water will be lost in the urine. So this is what is usually labeled as the diabetes insipidus. Next, the osmotic diuresis. If there is a non-electrolyte osmotic substance present in the urine, like if the patient has excessive diabetes, uncontrolled diabetes, or if the patient is having is being pushing an osmotic substance like mannitol due to some other indication, these can draw the water as they pass in the urine. So this can cause osmotic diuresis. And the release of vasopressinase, which is an enzyme which metabolizes the vasopressin prematurely. So this can also lead to the diabetes insipidus. That is also called as peripheral diabetes insipidus. Or the water loss is occurring from the GI sources like the vomiting or the osmotic kind of diarrhea. Or the cutaneous loss, patient is losing excessive sweating, or the respiratory loss if the patient has the hyperventilation secondary to some alkalosis or the compensatory mechanism for acidosis. These patients are expected to or can have the uh, hypernatremia if their water intake is inadequate. This is a very, very important thing. Or so before going to the further discussion, we need to know what are the differences between the dehydration and hypovolemia. Although both of these terminologies seems to be look similar, or in fact they are used interchangeably in many conditions, these both are entirely different things. Hypovolemia is basically due to ECF volume reduction. So this is a loss of both water and electrolytes from the body, so which is invariably associated with the low tissue perfusion. Whereas dehydration is the loss of water only. It is the loss of only electrolyte free water. So here the water loss is from the total body water, not only from the extracellular fluid. Whereas in case of hypovolemia, the water and the electrolyte loss is only from the ECF. So I repeat again, dehydration is the loss of water only, whereas hypovolemia is the loss of water and electrolytes. So hypovolemia is a more serious condition, is more what you call dangerous to have a tissue perfusion, whereas dehydration is usually less dangerous compared to the hypovolemia. So any patient with a dehydration will is expected to have a hypernatremia, as this is due to the loss of water only. As due to hypovolemia, there are some conditions where the electrolyte loss might be equal to or sometimes greater than the water loss in case of hypovolemia. So they may or may not have the hypernatremia. Whereas any condition which can cause dehydration, that is the loss of exclusive water from the body, is expected to have a hypernatremia. So dehydration and hypovolemia, you need to be very careful. Even some senior examiners may ask you the questions of the difference between the dehydration and hypovolemia. So other cause of this primary water deficit is, and there is a sudden shift of water from the extracellular compartment to the intracellular compartment. This can occur due to sudden increase in the osmolality in the intracellular compartment. Like if there is a gain of effective osmoles suddenly the intracellular compartment, it can occur during the seizure due to the breakdown of the muscle protein tissue and rhabdomyolysis. The effective osmoles have been accumulated in the intracellular fluid. So there is an increased osmolarity in the intracellular compartment, which brings the water from the ECF to the ICF, causing the uh, hypernatremia in the ECF. This is very common and considerable issue in case of an emergency. The very rare cause of the hypernatremia is the primary gain of this sodium. It is very rare actually, and it is usually a case of iatrogenic things like If you're administering your patients with a very high concentration of the sodium and potassium than their concentration in the urine, especially during the osmotic water diuresis, or if you're directly infusing your patient the hypertonic sodium chloride or the sodium bicarbonate in the oliguric patient in the background of kidney failure, they are very prone to develop this hypernatremia. And an ingestion of sea water, which is a very rare case, the salt poisoning, or the replacing sugar by the salt in a feeding formula in infants, as infants cannot tell you the taste of the food. Sometimes accidentally their sugar has been replaced by a salt, where it cannot, the salt overload can occur in the infants. So the what body does if we are tend to develop this hypernatremia. So anytime if our sodium goes high, there is an osmostat which is being situated in the hypothalamus, which gets sensed the plasma osmolality and which give the basic two signals. The one is it stimulates the thirst, which makes us to take a lot of waters, and it also gives the signals to the posterior pituitary to release the stored antidiuretic hormone, which goes to the kidney to act, causing reabsorption of water, correcting the existing water deficit. So this usually prevents the development of hypernatremia in normal people. So if there is any abnormality, if the osmostat is not good, if the thirst center is not properly working, if the ADH is not producing, or if ADH is not acting, any of these conditions will be unable to correct the primary water deficit, so tends to worsen the hypernatremia in patients. So as I'm telling you, so as a response to hypernatremia, if at all we are tend to have hypernatremia in any case, if the plasma sodium tends to rise or if it goes in a rising direction, the water control system gets activated in the body. So this water controlling system is designated to lower this plasma sodium by further, which decreases the what you call brain cell size. So this has to be prevented. Otherwise, it will tend to develop over hypernatremia. So how this water control system acts? As I'm telling you, it acts by the stimulation of thirst and the water reabsorption of the kidneys by the mechanism of ADH. So whenever you during a summer time, if you're sweating a lot, you need to you will develop a lot of thirst, which tends to uh, make you take the adequate amount of water, which usually prevents in case of to develop hypernatremia. Imagine you are not having thirst, even if you are dehydrated, even if you are developing excessive sweating. If your thirst center is not stimulated, you will not take the adequate water. Here, the patient is definitely going to have a severe hypernatremia. So, in any particular patient, it is virtually impossible to have the hypernatremia if the thirst response is intact and the water is available. So only if the thirst center is not intact or if the water is not available, even if thirst is normal, then only the patient is going to get the hypernatremia. So if at all you see a patient of hypernatremia, that to us clinically significant one, you need to search the reason for the impaired thirst or the inavailability or the in excess of the water. So without the abnormality of these two functions, the hypernatremia is very difficult to develop. Even if the water reabsorption is not occurring in the kidney, if the thirst is normal, the patient will not develop hypernatremia. This is the case of diabetes insipidus. The diabetes insipidus patients usually does not have hypernatremia if their thirst center is intact or if the thirst mechanism is intact. Only they tend to have a mild higher normal sodium, maybe it may be around 143, 145, 146. But the overt hypernatremia is very common, very less common in case of a pure diabetes insipidus. Although kidney is not reabsorbing the water, since the thirst mechanism is intact, these people tend to consume the water which is adequate to maintain the extracellular water. So, if a diabetes insipidus patient usually presents with what you call the polyuria or some amount of dehydration or polydipsia maybe. So hypernatremia is very less common in a pure diabetes insipidus. So if a diabetes insipidus patient develops hypernatremia, there has to be an associated impaired thirst or inavailability of water, which is to be suspected. So how? So I think I have made a point to understand the importance of the mechanism of thirst in the case of hypernatremia here. So this water reabsorption of the kidneys, everybody of us know, we also discussed in the last class also, that this acts through the hormone called vasopressin. If the vasopressin is not present, or if the vasopressin is present but it cannot act on the kidneys due to resistance, this hypernatremia can develop if the thirst is also impaired. So whenever the vasopressin is being acting properly, the urine flow decreases, the urine osmolality increases. If this water reabsorption does not occur in the kidney, which results in an increased urinary flow rate and decreased urinary osmolality. So this concept of the urinary flow rate and the urinary osmolality is very, very important to understand here. So if we see this graph, as the ADH secretion gets stimulated and the action goes on occurring in the body, the water reabsorption gets continued in the collecting depths. So as the process goes on and goes on, there reaches the maximum ADH action. So at this maximum ADH action, almost all of the water which is being filtrated in the glomerulus is being reabsorbed from the collecting depths. So if the vasopressin is acting properly, the urine flow rate is usually very low, whereas the urine osmolarity is very high. So this has been the concept of the urine flow rate and urine osmolarity when the plasma vasopressin acts. What happens to these two factors when the vasopressin is not there or if it is not acting properly? So if vasopressin is not there, the urine flow rate is going to increase, whereas urine osmolarity is going to decrease because there is a loss of lots of water in the urine. So it tends to decrease the urine osmolarity. I will explain this concept again here. So if the vasopressin is acting properly, the urine flow rate is going to decrease and the urine osmolarity is going to increase. Whereas if the vasopressin is not acting properly or if it is not getting secreted in response to the stimulus, then the urine flow rate is going to increase, whereas the urine osmolarity is going to decrease. This is the basic concept. And a lot of diagnosis of this hypernatremia is dependent on the concept of the urine osmolarity. Without having the urine osmolarity with you, it is very difficult to diagnose the cause of the hypernatremia in the patients. And to diagnose the concept of this is very, very important. What happens to urine osmolarity when there is vasopressin, and what happens to the urine osmolarity when the vasopressin is not there? So this hypernatremia can develop acutely in some patients, or this can also develop as a long-standing issue in majority of the patients. So what happens in case of an acute hypernatremia? So this acute hypernatremia, although in case of hyponatremia, we have got a standard duration of 48 hours. We have got a 48 hours duration as the cutoff. The hypernatremia per se does not have any cutoff of this 48 hours. Many of the people tend to consider acute hypernatremia as a 24-hour thing. So some books mentions as a 24 hours, some books mention as 48 hours. Although up to date mentions it as a 24 hours, and even the correction of this hypernatremia is going to occur in the next coming 24 hours. So we need to remember this is a 24-hour thing as a acute hypernatremia. So in this acute hypernatremia, there is a sudden decrease in the size of the cells in the body. As I told you, any hypernatremia, there's a cell shrinkage. And since this is developing very acutely, there's a sudden decrease in the cell size of the body. And whereas the most important organ which has been affected in this decrease in the size is the brain. So when the brain volume or a brain suddenly shrinks, the vessels coming from the surface of the skull become stretched, especially the veins. They become stretched, and there is a very high tendency of this to get rupture. So this is being the issue in case of acute hypernatremia. We discussed in the last class the issue in case of the acute hyponatremia is the cerebral edema. The issue in case of acute hypernatremia is the sudden shrinkage of cells, and this sudden shrinkage of cells can cause the rupture of the overlying vessels, which might lead to the subarachnoid or intracerebral hemorrhage for that matter. Whereas in case of chronic hypernatremia, this hypernatremia is usually slowly developing or it is a long standing. And here the cells in the brain have a time for adaptation. How they adopt? They adopt by gaining the effective osmoles. So they try to gain the effective osmoles as a function to reduce their cell size. So while this adaptation is going on, if we tends to lower this sodium suddenly, this might cause the brain to swell because whatever the extra osmoles it has gained, they cannot be lost quickly. So this may lead to cerebral edema and herniation. This has been very true in case of infants and neonates. This is a very rare phenomenon in case of adults. Even in the fastest correction in the hypernatremia, the adverse events have not been recorded in the adults. But infants, yes, we need to be very careful. We need to follow the strict guidelines of the management here, which we are going to discuss in the later class. So we will try to discuss the etiologies here again. As I was telling you, the causes of the hypernatremia, basically it is due to the loss of water, and rarely it is due to gain of water. If you see this loss of water, as we discussed previously, this can be from the kidney, this can be from the GI tract, this can be from the skin, etc. So skin losses, as both the transdermal or the active sweat loss can cause the hypernatremia if the loss is very excessive. Under normal conditions, the sweat volume is usually 500 to 700 ml per day. Whereas if the excessive sweating conditions like the fever, exercise, and the high temperature, the humid climates, the heat stroke, all these can cause the hypernatremia because the sweat is hypotonic to the plasma. So if this excessive sweating is not corrected by the adequate amount of water intake, this will definitely cause the hypernatremia in our patients. So this excessive hyper sweating, if it is associated with inadequate water intake, this usually causes hypernatremia. Whereas if there is an excessive sweating with the excessive water intake, as we discussed in the last uh, class, especially the exercise-induced hyponatremia, which has been very common due to improper education of the marathon runners who tend to take lots of water more than they required. So they tend to develop hyponatremia. So sweating can cause both hyponatremia and hyponatremia. The electrolyte abnormality depends on the amount of water taken by the person. If he is taking inadequate water, he will develop for hypernatremia. If he is taking excessive amount of water, then he will tend to develop the hyponatremia. So same in case of GI loss. If the excessive amount of GI loss, it is both from the upper and lower GI, can result in the hypernatremia, again if the water intake is inadequate. We discussed in the last class that the secretory diarrheas, where there is the active secretion of this intracellular thing in the diarrhea, which is usually causes the hyponatremia. Whereas in case of the osmotic diarrhea, this is due to a presence of an osmotic substance in the intestine, majorly due to the constipation drug abuse, which tends to cause the hyponatremia as the loss is the hypotonic. Whereas in case of secretory diarrhea, it is usually hyponatremia, as the secretion has the uh, plasma osmolality, which is similar to the ECF compartment. Whereas in case of an osmotic diarrhea, whatever the fluid which is going on is usually hypotonic secondary to the ECF. And the urinary losses we discussed, it tends to occur in two conditions. One is either diabetes insipidus or the osmotic diuresis. In case of diabetic insipidus, it is either due to decreased release of ADH. which is called as central diabetes insipidus, or even if it is releasing adequately, but it is not able to act on the collecting ducts, which causes the nephrogenic diabetes insipidus. Although this most patients of the diabetes insipidus, the ADH is not acting properly, these patients will usually have a normal thirst mechanism. So they usually does not develop any overt hypernatremia. Their sodium may be higher than the normal range, like it may be around 145, 144, 146, etc. But to develop overt hypernatremia, they have to have the following abnormalities. Either the thirst is improper, or there is a lesion which is being involved in the central diabetes insipidus is also involving the thirst center. For example, if the patient can have a tuberculosis, if the patient has received the radiation for the brain tumor, if patient is having a primary brain tumor which is being causing this diabetes insipidus of a central cause, which if it is also involving the thirst center, yes, these patients are definitely going to have the hypernatremia. And infants and young children with the diabetes insipidus, it is very, very important. There are particular conditions in the infants which can cause diabetes insipidus. They are very much prone to develop the hypernatremia because of the inadequate water intake. And in the post-operative period, when the patient is in the altered sensorium, and the older patient again are very prone to develop the hypernatremia in case of diabetes insipidus. In case of osmotic diuresis, as I told you, there is a non-reabsorbable and non-electrolyte osmotically active substances there in the body. While passing through the kidney, it draws the water, which causes excessive water loss in the urine. So there are three such substances that can cause, like glucose, mannitol, and urea. Among this, the glucose and mannitol are osmotically active. What that means is this can diffuse in and out of the cell very freely. So whenever there is excessive mannitol or glucose in the extracellular fluid compartment, first it draws water from the ICF, causing dilutional hyponatremia. And after the action is over, they are completely excreted in the urine. So while passing in the urine, they draws excessive water and goes away, so which can cause the hypernatremia. And this situation holds good even in case of diabetes ketoacidosis, where in the active, when you see the patient first of a diabetic ketoacidosis, the sodium will be normal or slightly lower because there is a lot of glucose inside the extracellular compartment, which draws this water from the intracellular compartment, causing the dilutional hyponatremia. So once this excessive glucose starts appearing in the urine, these patients will lose excessive amount of water in the urine. So this dehydration comes into the picture in the later part, where they manifest with the hypernatremia. So you need to be very careful in case of diabetic ketoacidosis while dealing with the sodium. Similarly, the mannitol does the same thing. Whereas urea is an osmotically inactive substance. It cannot freely diffuse in and out of the cell. So urea, whenever you give, it completely appears in the urine. It does not do anything in case of the when it is situated in the intravascular compartment. It draws only water when it is there in the kidney. So since it is an ineffective osmolar, it produces only hypernatremia, whereas glucose and mannitol can cause both hypo as well as hypernatremia depending on the situation and depending on the time of this given. So I was telling you the diabetic insipidus patients, if to have a chronic hypernatremia, they also need to have the thirst abnormality in our patients. So this hypernatremia usually occurs in the absence of increased water loss if there is primary hypothalamic disease which is impairing the thirst, which is causing hypodipsia in our patient. So any defect in the thirst, even without diabetes insipidus, especially in case of children, can cause this hypernatremia. So as an example, if the patient of an infant of a holoprosencephaly, here the condition in which there is an abnormality or a dysplasia of the brain midline structures, the hypothalamus, pituitary are also midline structures. So there is a dysplasia of pituitary and hypothalamus, where there is both impairment of the thirst and the diabetes insipidus. Sometimes they may show like even if their osmolarity is very high, even if it is above 330, they may not show any signs of thirst. Even if they are dehydrated, they are not thirsty to drink water. So how will you manage these patients? Just ask them to have a forced water intake, just to give them a chart, alarms to drink water regularly. This is usually sufficient to have the normal serum sodium in these kind of patients. Whereas there is one particular condition that is called as adipsic diabetes insipidus. As I told you, the diabetes insipidus patients alone, the thirst is usually normal. Whenever there is a diabetes insipidus, that is the central diabetes insipidus, where the ADH secretion is also lost along with the thirst, which is being impaired, is called as adipsic diabetes insipidus. The earlier terminology was called as the essential hypernatremia, as the hypernatremia was an essential part of this condition. Hypernatremia cannot escape from this condition. This is also labeled as central diabetes insipidus with deficient thirst. Here, the affected patients are having a chronic or the recurrent episodes of the hypernatremia, where their sodiums might range from 155 to 190. So even with this amount of sodium, they may be completely asymptomatic because this is a chronic issue. The brain cells usually adapt for the chronic higher concentration of sodium. So in which condition this particular thing occurs is, it usually occurs in case of the congenital or acquired conditions of the central nervous systems. Whenever there is a lesion which is involving both the posterior pituitary and the hypothalamus and the third center. The most common cause of this adipsic diabetes insipidus is the septo-optic dysplasia, and this can be the MCQ question. So this particular septo-optic dysplasia, along with some tumors like germinoma, which tends to involve the midline structures, and if there is a rupture or an abnormal clipping of this anterior communicating artery, which passes just above the posterior pituitary in the circle of Willis, and CNS sarcoidosis, where there is a granulomatous condition which can involve both the posterior pituitary and the hypothalamus, can cause the adipsic diabetes insipidus. So whenever you see an adipsic diabetes insipidus patient, you need to get a brain imaging. In the 90% of the case, you are going to get a diagnosis because of anatomical abnormality. Whereas if there is a patient of adipsic diabetes insipidus and his brain imaging is normal, he does not have any abnormality over per se. In this particular condition, the patient can have these autoantibodies, the sodium channel in the osmoreceptors. So this sodium channel is a sodium sensing receptor in the hypothalamus. The autoantibodies can be produced from this channel, especially in case of an autoimmune encephalitis or paraneoplastic syndromes, or a broader involvement in a classic autoantibody syndromes like SLE. These patients can have an adipsic diabetic insipidus, where there are young patients which are having chronic or recurrent hypernatremia, where there is no vasopressin response and there is no thirst also. So the rare causes of this hypernatremia, apart from the loss of the free water, is the gain of the sodium. So this can occur in the sodium overload conditions. So this can be acute and sometimes very severe. So this can usually occur when there is an iatrogenic administration of this hypertonic sodium solutions. So in which conditions this iatrogenic administration occurs? It can be accidental or a non-accidental salt poisoning in infants, as I was discussing in the late class, sorry, in the previous slides. The infants which they cannot tell the taste, sometimes their feed formula has been replaced by the salt instead of sugar. This is very common in case of a negligent parents. The other conditions are the hypertonic sodium bicarbonate in the treatment of metabolic acidosis. If a patient has metabolic acidosis, to correct acidosis, we tend to give sodium bicarbonate. Since it is hypertonic to the plasma, it can cause sodium overload if there is an inadvertent or excessive injection. Hypertonic saline injection in case of traumatic head injury to prevent cerebral edema can develop the sodium overload. And hypertonic saline irrigation of the hydrated cysts. So during the management of hydrated cyst, after the codicidal agent has been ingested, there is a habit of irrigating this cyst with the hypertonic saline, especially the 20%, 30% salines. So if in inadvertent injection of this high concentration or hypertonic saline into the intravascular compartment, or an excessive irrigation causing the reabsorption of this into the vascular compartment can lead to the sodium overload. Uh, there are some instances where this hypodermic saline has been administered into the uterus to induce the medical abortion, can cause the sodium overload. And it's very rarely a massive salt ingestion in case of a seawater drowning or psychiatric patients. Salt poisoning again is been a very less common conditions in our part of area. There is a possibility of a surreptitious and intentional salt poisoning as a form of child abuse can occur. A single tablespoon of this salt, sodium chloride, contains 100 milliequivalents of sodium, which can increase the serum sodium by 10 milliequivalent in case of a 10 kg child. So this is very, very important. The children are very prone for this hypernatremia in case of an abuse. Or if there is, as I told you, accidental substitution of this salt for the sugar. And in some parts of the world, there is a custom called salting of the newborns, especially in Turkey, where they tend to do a bath of their newborn child in case of a highly concentrated salt with the water. So this, due to absorption through the subcutaneous route, can cause the salt poisoning. So how this hypernatremia is going to manifest in our patients? So hypernatremia, as we know, if there is an acute abnormality, can cause the rapid decrease in the brain cell volume, which can cause the rupture of the vessels, can cause the subarachnoid hemorrhage or a intracerebral hemorrhage, or probably the irreversible neurological damage. And sometimes it can also cause a demyelinating lesions similar to ODS. As we discussed in the last class, in the case of chronic hyponatremia, there is a cerebral adaptation. If there is a sudden correction of this hyponatremia, there is a shrinkage which can cause the osmotic demyelination syndrome. A similar kind of syndrome can also occur in case of acute hypernatremia if it is not corrected properly. And as a syndrome, as a symptoms of the brain shrinkage, it can cause lethargy, weakness, irritability, and can progress to the seizures and coma. And usually the symptoms does not appear till the serum sodium rises above the 158 milliequivalents per liter, whereas the mortality has been very highest if there is a huge increase in serum sodium by 180. In the same way, the chronic hypernatremia is usually asymptomatic because the cellular adaptation is going to take place. So even if the symptoms present, it has been very difficult to distinguish because these hypernatremic chronic patients usually have an underlying neurological condition. So you can't just differentiate the symptoms due to their primary condition or the hypernatremia. But overall, per se, chronic hypernatremia in our patient, which has been carrying from the outside or developing inside the hospital, has an increased mortality, increased hospital stay, increased hospital bill, and also morbidity. The deaths are also increases. And the rapid correction of this chronic hypernatremia has been the issue only in the infants. The correction has to be very slow. It is less than the 10 to 12 milliequivalents per day. That is less than 0.5 milliequivalents per hour. This is very, very important. Whereas in adults, the rapid correction has not been shown to do any adverse outcomes. The risk of cerebral edema is less. And another issue with this chronic hypernatremia in adults is they're always undertreated. Many of the people tend to overlook this hypernatremia as a symptom, as an abnormality. But hypernatremia is being indicated as a adequacy of the care in case of ICU settings. So we need to manage this hypernatremia very properly to prevent the mortality and also the morbidity in our patients. So how we are going to diagnose the cause of this hypernatremia? As I told you, hypernatremia is just a manifestation of an underlying abnormality. The cause of this hypernatremia is usually evident from the history majority of the times. So in adults, it is most often, as we discussed, is due to water losses. In older patients whose water loss is not being replaced by the inadequate water intake or the non-availability of the water intake. On the other hand, the hypothalamic lesion affecting thirst center should be strongly suspected in an alert patient with access to water who has sodium concentration that is above 150. So if at all you are seeing a patient who is carrying the sodium report of above 150 who is alert, who has an access to water, you need to have the brain imaging directly straight away, because the thirst center is definitely abnormal in this patient, and he can also have the possibility of adiposic hypernatremia in our patient. So how we are going to evaluate a patient? The majority of the diagnosis are based on the urine osmolality here. Sometimes we need to know the urine electrolytes to differentiate the further causes and the response of this urine osmolality to the administration of ADH, especially if the diabetes insipidus is being suspected, to differentiate whether the cause is the central or the uh, nephrogenic. Although water deprivation test was used in the earlier day of time, nowadays it is being gone. Even the newer Harrison, as an evaluation of polyuria, does not involve the water deprivation test to differentiate between central and nephrogenic. The direct straight away we can measure the plasma ADH, where it is usually low in case of central, it is very high in case of ADH, along with the central bright spot in the MRA coronal section. So that is the usual way where we manage polyuria in our patient. So only if you're suspecting there is something called as partial diabetes insipidus, the use of water deprivation test or hypotonic saline load may come. Otherwise, these tests have become not necessary nowadays, as water deprivation test is very tedious to perform. So before going to know the evaluative aspects, first let's repeat the normal response. If at all there is a rise in serum sodium or a tendency to rise in serum sodium, there is a rise in plasma osmolarity, which does two things. One is it stimulates the thirst, which tends to take the excess water, and it secretes the ADH, which increases the reabsorption of the water. So as a result, the urine becomes concentrated, leading to reduced flow and increased urine osmolarity. So rise in serum tends to cause a rise in urine osmolarity. This is directly proportional. If at all this rise in sodium is not causing this rise in urine osmolarity, that means urine osmolarity is still low in the background of the high plasma sodium, we need to suspect the reduced water reabsorption, that is diabetes insipidus. Therefore, if any patient is having an intact hypothalamus and renal functions in the presence of hypernatremia, their urine osmolarity should be high, that is above 600 milliosmoles per kg. This is very, very important. If this is not above 600 milliosmoles per kg in the presence of hypernatremia, you need to suspect the diabetes insipidus in this patient. So if this urinary osmolarity is above 600 in this particular category, even if you give any excess ADH from the exogenous source, it is not going to produce any further rise, as it is already acting maximally. So while managing the hypernatremia and while evaluating, if you see a patient of urine osmolarity which is low, that means there is no reabsorption of water in the kidneys. So this directly diagnoses the patient as diabetes insipidus with a high urine output and a very low urine osmolarity. Yes, to differentiate between central and diabetes insipidus, you need to assess the response to exogenous desmopressin, that is a synthetic analog of vasopressin. If there is a response to the exogenously administered vasopressin, then the cause was the central diabetes insipidus. Even if you are giving this desmopressin exogenously, if it is not able to concentrate the urine, that means the cause is the nephrogenic diabetes insipidus. So it is as easy as looks here. So it is very easy to diagnose central diabetes insipidus and nephrogenic diabetes insipidus, although it is very difficult to diagnose the partial diabetes insipidus where there is some amount of secretion. But a pure central diabetes insipidus or a pure nephrogenic diabetes insipidus is very easy to diagnose, as desmopressin is readily available, urine osmolarity is readily available in majority of the labs. Even if urine osmolarity is not available, you can go for urine specific gravity to have a rough estimate. So the straight away the diagnosis of diabetes insipidus comes into picture. Many of the times when you hear the terminology called diabetes insipidus, many people tends to have an apprehension like it might be very difficult to diagnose, etc. It is not the case. Whenever you see a case of hypernatremia, if the urine osmolality is very low, which should not have been the case, then it is diabetes insipidus directly. Okay, what if the urine osmolality is intermediate? Like if it is 300 to 600, it is usually less, it is less than 600, but it is intermediate. Still, it can be diabetes insipidus, but there comes another possibility of the free water loss in the urine, that is osmotic diuresis. So to differentiate this particular osmotic diuresis, we need to measure something called as total solute excretion in the kidneys, which is usually the product of the urine osmolarity and the urine output. So normal total solute excretion in the kidneys is 600 to 900. If it is above 1000 milliosmoles per day, then it indicates the presence of an osmotically active substance, and this particular entity does not respond to any exogenously administered ADH because ADH is already acting normally in this patient. Okay, what if urine osmolarity is high in case of hypernatremia? Yes, urine osmolarity should be high. That means the free water loss is not from the kidney, it is from the extra-renal cause. It may be from the skin, it may be from the GI tract, it may be from the what you call it, sweat, etc. So here the diagnosis becomes straightforward depending on the history. But the possibility of the partial diabetes insipidus does exist in this case. I'm waiting for the response of how to diagnose the partial diabetes insipidus from the students here. So how to treat the hypernatremia in the adults? Uh, as I told you, it is not so difficult in case of the hypernatremia as compared to hyponatremia. Here, just the correction requires the administration of a hypotonic fluid or the isotonic fluid to correct the water deficit and to replace the ongoing water loss. Since there is a loss of water in the body, just give the water to the patient and just have a mind to replace the ongoing loss also. Like people usually tend to calculate the water deficit, they just replace the water deficit, which usually does not correct the entire sodium. We have to replace the ongoing losses also here. So patients with hypernatremia usually sometimes have a serious underlying conditions. So it is very difficult to manage these kind of patients in a OPD settings, especially in case of an elderly whose thirst is being impaired and whose conscious is being impaired, and infants. So it's very difficult to manage in OPD basis. So they usually need to be hospitalized for the management. So what is the equation here? The equation is 3:1. That means in general, the positive balance of a 3 ml of free water per kg will lower the sodium by 1 milliequivalent liter. What is this does mean? If the person is weighing 60 kg, 3 ml per kg, that means 180 ml of the free water which is being given to the patient lowers the sodium by 1 milliequivalent. This is the basic funda. You need to remember this rule, that is 3:1 rule. Every 3 ml per kg of free water given to the patient reduces the sodium by 1 milliequivalent approximately. This is very, very important. So what to do in case of chronic hypernatremia patient? So this chronic hypernatremia patient, we are going to give the patient the dilute fluids. That is, the fluid of choice in case of hypernatremia is the dextrose-free, so 5% dextrose water. This is an electrolyte-free water, which we usually prefer in case of the hypernatremia. People can also choose the half saline, that is what is called as 0.45% saline. But fluid of choice, whenever there is a conflict between these two, is a 5% dextrose, which is being given intravenously at 1.35 ml per kg per hour up to the maximum of 150 ml per hour. So 1.35 ml, it is very easy to remember also. So any 50 kg patient give 70 ml per hour, 5% dextrose. If 70 kg patient give 100 ml per hour, 5% dextrose. And if the patient is clinically stable, like if the patient has a normal sensorium, he can drink water adequately, the hypernatremia can also be corrected using giving the oral rehydration or the administration of the water through the nasogastric tube. What is the goal of the correction here? The basic goal of the correction is to lower this serum sodium by 10 milliequivalent in case of 24 hours and not more than 20 milliequivalent in 24 hours. This holds good for infants. In adults, it is better to follow this rule, but even if there is an overcorrection, you need not fear of having a cerebral edema in case of chronic hypernatremia. In case of an acute hypernatremia, the deficit has to be corrected within 24 hours. That means the whole deficit of free water has to be corrected within 24 hours. So here, as I told you, every 3 ml decreases the sodium by 1. So we are giving the 5% dextrose at a rate of 3 to 6 ml per kg per hour, up to a maximum of 666 ml per hour. So this is a huge amount of fluid we are going to give the patient, because we are correcting the whole total body water deficit in less than 24 hours. Since we are giving the dextrose containing fluid here, we need to monitor the blood glucose every hourly, especially in case of diabetics. We need to use the insulin simultaneously if possible. And once the serum sodium is been lowered to 145, this amount of the fluid can be reduced to 1 ml per kg per hour. And if the patient, along with this hypernatremia, has a diabetes insipidus, which have been diagnosed, the patient can also be given the desmopressin therapy to lower the sodium, especially in case of central diabetes insipidus. So what are the rationale of the things whichever I have told you to manage? The first thing is always estimate the water deficit. As there is a water deficit which has been 100% in our patient, we need to estimate how much the patient is deficit of water. After calculating the water deficit, determine the rate of correction. How you should correct this thing. If there is an acute hypernatremia, you need to correct the entire things in less than 24 hours. If there is a chronic hypernatremia, the 10 milliequivalent per 24 hour is the cutoff. Then, according to the rate, determine the feed regimen and add the concurrent volume or potassium deficits if at all it is available. Like if the patient can have a hypokalemia pre-existing to hypernatremia, you need to add this potassium infusion to the dextrose containing fluids. So how to calculate the total water deficit? The total water deficit is usually the percentage of body water into the mass, that is kg body weight, divided by the sodium deficit. That is the current sodium minus the ideal or the determined sodium divided by the determined sodium. So this total body water changes according to the age. In adults, we usually take the 50% as the thing. In neonates, it's very high. The 80% of their body water is total body mass is water. So in adults, it is usually 50%. That is half of their body weight is usually formed of water. Like for example, if the adult is weighing 70 kg, 35 kg of this weight is due to his water content. So as an example, if the 70 kilo patient has a serum sodium of 167, how to calculate this free water deficit? As I told you, it is percentage of body water into the mass. As is an adult, it is usually the 50% of this 70, that is 35 into the sodium, where the water deficit is coming to the 5.2 liters or 5.3 liters. So if it is an acute hypernatremia, this 5.3 liters is to be corrected within 24 hours. If this is a chronic hypernatremia, this 5.3 liters can be corrected very slowly. So to do that, you need to determine the rate of correction. As I told you, in case of a severe acute hypernatremia, it needs to be lowered rapidly to near normal within 24 hours. It is less than 24 hours, not even 24 hours, it is less than 24 hours. Whereas in case of chronic hypernatremia, the safe practice is to lower the sodium by less than 10, but the maximum limit is 12 here. Acute hypernatremia can also be treated with a hemodialysis or a continuous veno-venous hemofiltration, especially in case of a severe salt overload. The patient can be straight away taken into the dialysis to remove the excess sodium. So how to determine this fluid replacement regimen? In case of an acute hypernatremia, pardon me for the mistake here. In case of an acute hypernatremia, the entire deficit needs to be corrected within the 24 hours. So whatever the water deficit we have been calculated here, we need to divide it by 24 hours. For example, if the total body deficit is 4.8 8 liter. So this in ml means 4,800 ml divided by 24. That means 200 ml per hour is the hourly infusion rate in case of an acute hypernatremia. This is very simple. We just need to have a total body water deficit in managing the hypernatremia. So in acute hypernatremia, we are going to correct this entire water deficit. For example, the 4.8 liters is to be given in the less than 24 hours. Even it can be more than 200 ml per hour. You can do 300 ml per hour infusion to correct this in less than 24 hours. But in case of chronic hypernatremia, only some amount of this the deficit is being corrected in case of 24 hours. The not whole of the fluid deficit is not corrected in 24 hours. So just to correct the 10 milliequivalent, water is sufficient in case of first 24 hours. As I told you, to decrease sodium by 1, we need 3 ml per kg. So to decrease 10, we need 30 ml per kg fluid. So 30 ml overall. I will come again here. So the fraction of total water deficit is being replaced in the first 24 hours in case of chronic hypernatremia. So as I told you in the previous slides, every 3 ml per kg increase in the free water decreases the sodium by 1 milliequivalent. So to correct 10, we need to do the 30 ml of this correction. So this comes around 30 ml per kg into 10. For example, if the body weight is 60, 6 into 3, 180, 180 into 10, it is 1800. So 1800 divided by 24 is the amount of correction in the first 24 hours. I think I have understood, make you understand the concept here. So along with this total free water which you are correcting, you need to add the fluid for the ongoing loss. If at all the free loss is from the urine, you need to use this formula, that is urine volume into 1 minus the urinary electrolytes divided by the serum electrolytes, that is majorly sodium, to add to the existing fluid loss. If the person is having the fluid loss from the GI tract, you can estimate the amount of fluid in a rough way. For every stool passed, you can add 150 ml or 200 ml, etc. And to this, you need to add the integumentary loss, which normally occurs in the body, that is 1 liter per day, is to be added to the total water deficit. So this is an example here. Here there is a patient who is a 53-year-old with a multiple hospital visits, comes with the complaints of cough of since 1 year and unsteady gait since 6 months. With a recent history, the patient had a multiple hospital visits. Where with a recent ER visit, she was told to have a kidney function, to consult a nephrologist. On the admission, her sodium was 183, which has been very high, and the weight is 74, BMI is 22, heart rate is normal, blood pressure is okay, and the physical exam is completely normal, and she is neurologically intact. Her oral mucosa is moist. There is no signs of dehydration. So as I told you, in any patient with a significant hypernatremia, if he is conscious enough to drink water, or if he has access of water, if at all he's coming with a hypernatremia, you need to uh, diagnose the condition as an abnormal thirst. So since here the questions are whether it is an acute or chronic, since the patient is symptomatically normal, it is usually chronic. So what is the volume status? See, usually have euvolemia. So what is the cause? As I'm telling you, the patient does not have any history of the water loss from the any source. The patient does not have the history of the polyuria also. Apart from cough since 1 year, unsteady gait since 1 year, patient does not have any symptoms. So if you take her the lab values, her hemoglobin is 15, her PCV is 46, TLC is normal, platelets are normal. Urine osmolality is very high. That means the kidney is functioning properly. That means ADH is functioning properly. So patient does not have diabetes insipidus. So with the kidney being properly working properly, the patient is not having thirst. Yet the patient has hypernatremia. That means there is an abnormal thirst. So we need to go for the brain imaging. So in this particular patient, the brain imaging showed the extensive abnormal enhancement of leptomeninges, the neurosarcoidosis was suspected. So to rule out, the CT thorax was done, which showed the hilar and subcarinal lymph node enlargement. The biopsy showed the non-casing granuloma. So the final diagnosis of this patient was the adipsic hypernatremia secondary to the neurosarcoidosis. So as a part of management, we need to calculate the total free water deficit. The weight is being given here. You can practice this correction in your home, etc. So the basic treatment or the fundamental treatment is the correction of the cause with the systemic steroids, which is the indication in case of neurosarcoidosis here. So this particular study showed that even with the rapid correction of this hypernatremia, both in case of the uh, person of hypernatremia coming to the hospital or hypernatremia which has been hospital acquired, does not show any significant differences in case of the management. Even with the rapid correction, there are no episodes of seizures, cerebral edema, or altered sensorium in the patients. So I think the rapid correction, especially in case of adults, is not a fearsome thing. Only in case of infants, we need to be very careful. So as I was telling you in the last slides, the hypernatremia is an indicator of quality of an intensive care unit. This article has been published as early as in 1999. So even after 10 years, the situation has remained the same. Even the hypernatremia has been the indicator of quality of intensive care unit. To know how the intensive care is functioning, whether it's functioning properly or not, just check the sodium of the patients. If the majority of the patients have the hypernatremia, that means the fluid management is being basically wrong in this particular ICU. They need to revise their concepts regarding the fluid management. So again, to revise the things here, the normal is usually the sodium and water are the balance in our body. So in case of the first primary condition where there is an excessive salt intake with the normal water, or the gain in sodium is more than the gain in water, can occur in case of an excessive salt intake or if any iatrogenic fluid administration. So key feature here is a high urine osmolality because ADH is normal and these patients are hypervolemic. In the second cause, there is a normal water loss from the urine or GI tract or sweat, which is usually unreplaced. They tend to have a mild hypernatremia. So again, the ADH is normal, so they are expected to have a high urine osmolality here. And the volume status, they may be euvolemic because of ADH normal function. Whereas if the water loss is excessive, whether it is from the extrarenal loss or from the abnormal renal loss, if there is abnormal renal loss, the urine osmolality will be very low. There is inability to make urine concentrated. Whereas if there is an extra renal water loss, the urine becomes normally concentrated, and these patients tend to have the hypovolemia, whereas the abnormal renal water loss patients tend to have, or they're usually euvolemic. So I think this is a rapid revision here. So the hypernatremia concepts I have made clear for you guys. This is not so difficult as you think. It's just a loss of water from the body. If the patient is conscious enough, if his patient is being given an adequate amount of water to drink, although he has hypernatremia, that means his thirst has been completely gone. You need to have a brain imaging to rule out the thirst abnormality here. So I think I have made the point. Thank you. Thank you very much.